Hello, today we will learn about the Abruptio Placentae, which is one of the variety of the antepartum hemorrhage. In short, we say APH. So let us see now what is Abruptio Placentae. You can see in this picture that there is placenta and this is there is blood collection behind the normally situated placenta. This is the normal placental location at the fundus. This is the uterus and the umbilical cord which is connecting the fetus and the placenta. You can see that there is blood collection behind the placenta between the uterine wall and the placenta. So this blood collection is the collection of Abruptio Placentae. Placenta. We will see the definition of APH, causes of APH, type of abruptio, etiology, differential diagnosis between the revealed and the concealed variety, the diagnosis, management, investigations and shock management, complications both maternal and fetal. The abruptio placentae term is used synonymously with accidental placentae, accidental hemorrhage, and other word is premature placental separation. It is one form of antepartum hemorrhage where bleeding occurs due to premature separation, that is from 28 weeks of gestation till before the delivery of the fetus of normally situated placenta. The incidence varies 1.5% in pregnancies overall, 0.3% in pregnancies at term, and 4.5% on histopathological examination whether APH is unrecognized. In this picture, you can see that there is placenta and on side of it this is the placenta and these are the clots which have collected behind the placenta. So presence of this clots behind the placenta confirms the diagnosis of Abruptio Placentae. Abruptio placenta has triad of symptoms. It has vaginal bleeding. Either vaginal bleeding is revealed, that is it is present, or it may be concealed, that is it may be absent. There is uterine hypertonus and there are signs of fetal distress. There are different types of Abruptio placentae. The concealed variety where the blood is collected behind the placenta but there is no trickling of the blood outside from the internal os. So as you can see that there is no blood outside, so it is a concealed variety. In the revealed variety, there is blood trickling out from the behind the placenta, it is trickling out from the internal os. So it is called as revealed variety. Then second other is marginal subchorionic variety, and the fourth one is the preplacental subamniotic variety. Now let us learn about the grading system for abruption. There are various grades from grade 0 to grade 1 to grade 2 and grade 3. As you can see from 0 to 1, 3, 0 to 3 grade, there will be increase in the severity of clinical presentation. Let us see how. In grade 0, less than 10% of the total placental surface has detached. The patient has no symptoms. However, a small rectoplacental clot is noted at birth. So you can correlate with the patient who has diagnosed as abruptio after the delivery. Then in grade 1, approximately 10 to 20% of the total placental surface has detached. Vaginal bleeding with mild uterine tenderness are noted. However, the mother and fetus are in no distress. So this is grade 1. In grade 2, approximately 20 to 50%, that means a large area of the total placental surface has detached. The patient has uterine tenderness and tetany. Bleeding can be concealed or is obvious. Signs of fetal distress are noted. The mother is not in hypovolemic shock in grade 2. In grade 3, more than 50% of the placental surface has detached. Uterine tetany is severe. Bleeding can be concealed or is obvious. The mother here is in shock and often experiencing coagulopathy, and fetal death has occurred. So grade 3, as you can now see, is the severest variety of abruptio. The etiology for abruptio placental is multifactorial. The number one very commonly seen is in hypertension in pregnancy. Second is multiparity, and it is more commonly seen in advanced age of the mother. Then women who smoke, usually hypoxia is labeled as the basic pathology, and then poor socioeconomic status and malnutrition. So all these are the common predisposing factors for the abruptio placentae. But number one should be remembered very clearly, that hypertension, it is very commonly seen in the hypertensive disease of the pregnancy. Then other causes are trauma, sudden uterine decompression, short cord supine hypotension syndrome, placental anomalies, folic acid deficiency, placenta implanted over septate uterus, torsion of the uterus, cocaine abuse, thrombophilias, and prior history of abruptio. Let us see the pathogenesis. Number one is hemorrhage into the decidua basalis and hematoma formation. That degeneration and necrosis of decidua basalis with adjacent placenta, and rupture of basal plate forming communication between hematoma and the intervillous space. Then the blood and the fluid percolates into the myometrium up to the serosal cord, and this gives the picture of covular uterus. There is port wine-like hemorrhages over the serosal surface of the uterus, and sometimes the serosa even splits open and the blood enters into the peritoneal cavity. Usually, the retroplacental hematoma is not evident. It is evident only after expulsion by features like depression on the maternal surface with clots area of infarction. In the covular uterus, as I have told you, dark port wine colored uterus surface is there. Subperitoneal petechial hemorrhages are present. Free blood in the peritoneum sometimes is present. Other organs may also be affected, like in liver, fibrin knots in sinusides are present. Kidney, ATN and ACN is seen. Shock and proteinuria. Let us see in this picture. On the left side, picture is showing concealed bleeding, and on the right side, the picture is showing revealed bleeding. As you can see in the left side, there is small blood collection behind the placenta, but there is no trickling of the blood outside from the cervical os. So this is the concealed variety. Whereas in revealed variety, there is trickling of the blood, there is separation of the marginal portion of the placenta, and the blood is trickling out from the cervical os. So this is how we can differentiate the concealed variety and the revealed variety. The revealed variety is 65 to 80% and the concealed variety is 20 to 35%. But remember, though it is less, but concealed variety is more dangerous as there is no blood seen outside, but patient goes into the hemorrhagic shock. So concealed variety needs to be suspected even when there is no blood visible outside, but patient is in shock and there are signs of fetal distress. Now let us try to identify by symptoms the differentiation between the revealed and the concealed or the mixed variety. In symptoms, number one is abdominal discomfort followed by vaginal bleeding. So in revealed bleeding, there is discomfort as well as visible bleeding from the vagina. In concealed variety, there is acute abdominal intense pain followed by slight or no vaginal bleeding. The characteristic of bleeding in the revealed variety is the dark colored continuous in revealed, whereas in concealed there is blood stained serous discharge continuously. The general condition in revealed variety is proportionate to the visible blood loss, whereas in concealed variety it is disproportionately. Patient is in shock. Usually the amount of bleeding is not there, but patient is in shock. Then uterine fundal height. It is proportionate to the gestational age. But in the concealed variety, because the blood is collected inside and it is finding no way to come out, the fundal height is more. So disproportionately enlarged fundal height is seen. Uterine feel is normal with local tenderness, whereas in concealed variety it is tense, tender and rigid. Fetal parts are easily identifiable in the revealed variety, whereas it is difficult to identify the fetal parts because of the blood collection. Fetal heart is usually present and fetal heart is usually absent in the concealed variety. Urine output is normal, whereas urine output is diminished in the concealed variety. Then hemoglobin is low, which is proportionate to the blood loss in revealed variety, whereas there is marked lower of the hemoglobin, which is disproportionate to the blood loss. So there is marked pallor in the concealed variety, whereas there is no obvious blood loss in the concealed variety. Coagulation profile is unchanged in the revealed variety, but there can be variable changes in the concealed variety. The urine for proteins may be absent, but it is usually present in the concealed variety. The differential diagnosis in the revealed variety, the most common differential diagnosis is placenta previa with intermediate bleeding. In the mixed or the concealed variety, with there is differential diagnosis is with a ruptured uterus, hypertonic uterine contractions, with rectus hematoma, twisted ovarian tumors, with appendicular perforations, and with volvulus. So these can be the possible differential diagnosis in mixed variety or concealed variety of the abruptio. Now let us see the differentiation between the placenta previa, which is the most common differential diagnosis of the abruptio placentae. Coming to the onset, usually the placenta previa is seen in the third trimester between 32 to 36 weeks, and this is the timing for abruptio placentae also. So bleeding mostly external, small to profuse in amount, which is bright red in color in placentae previa. Whereas in abruptio placentae, the blood is usually dark colored clotted blood in maybe concealed external dark hemorrhage or bloody amniotic fluid is seen in the abruptio. Then pain and uterine tenderness, usually the pain and uterine tenderness is absent in the placenta previa. Uterus is relaxed, soft, whereas the uterus is irritable and there is tenderness present in the abruptio placentae. Fetal heart rate is usually normal in placenta previa because there is small amount of bleeding in the placenta previa. But in abruptio placentae, because you can remember the grade from 0 to 3, in second and the third variety, the fetal heart rate is compromised because there is compromise in the fetal circulation. The presenting part is usually not engaged in the placenta previa because placenta previa, the placenta is in the lower uterine segment and the presenting part finds no place to get engaged, whereas this in abruptio placentae, the presenting part is engaged. Then coming to the shock, Usually, shock is not present unless the bleeding is excessive in placenta previa. But in abruptio placentae, moderate to severe degree of the shock is present. In the concealed variety, it may not be externally visible bleeding, but the patient is in shock. So think of abruptio placenta if you identify that the uterus is tender, tense, the fetal heart rate is irregular, and there may be externally revealed bleeding, there may be absent external bleeding. Then last is delivery. Delivery may be delayed depending on the size or the gestational age of the fetus and amount of bleeding in placenta previa. But in abruptio placenta, immediate delivery by cesarean section is warranted because the fetus is getting compromised because the fetal circulation is suddenly cut short. The prognosis of abruptio placentae depends on the clinical type, the degree of placental separation, interval between placental separation and the baby delivery, and efficiency of the treatment. And bleeding is always maternal here. So in this you can see that always remember the grades from 0 to 1, 2, 3. Then the surface area, amount of placenta which is separated, whether it is 10%, 20%, 50% or more than 50%. And a very quick action needs to be taken, that is shorter the duration between the diagnosis and the delivery of the baby, the better is the outcome. And bleeding here is always maternal, so blood replacement is very important in abruptio placentae. Now coming to the complications, maternal complications, number one is maternal mortality, hypovolemic shock, then acute renal failure, which is seen in 10% of the cases with severe abruptio. Another sequelae of abruptio is DIC, that is 30% in cases of severe abruptio. Because of the excessive blood loss, most of the coagulation components are consumed, and that is why these women, they are at high risk of developing DIC. Then postpartum hemorrhage, Sheehan syndrome, and there is very high chance of operative delivery. Now few words about the covular uterus, because this can be a short note in the exam also. Covular uterus is due to extravasation of the blood in the myometrium and in the serosal surface. Uterus appearance is port wine color. The management is usually conservative. It rarely causes PPH as blood interferes with the uterine contractility. Here you can see the picture of the covular uterus, and you can see that there is serosal surface, there is port wine like hemorrhages present. Now the cause of DIC, there is release of thromboplastin in circulation, intravascular formation of fibrin, consumption of coagulation factors, activation of the fibrinolytic system. Only 10% of abruption shows significant coagulation abnormalities. Persistent oozing at site of venipuncture, bleeding from mucous membranes of the mouth and nose. All these are indications of DIC. The women may go into shock when the blood loss is more than 30 to 40% of the total blood volume. Therefore, first step of management is stabilization of hemodynamics of the mother. If left unattended, shock may lead to coagulopathy, acute renal failure, and Sheehan syndrome. So management of shock is the bottom line in abruptio placentae. So at one point you have to manage the shock, and at the same time simultaneously you have to arrange for the quick delivery of the fetus by cesarean section. The complications of the fetus are intrauterine death, as you have seen in grade 4, where the placental separation is more than 50% of the surface area. There is high chance of intrauterine fetal death. Then perinatal mortality. If a premature baby is delivered, then also there is high chance of perinatal mortality, fetal growth restriction and preterm birth. Now coming to the management, there are first is prevention. So elimination of the known factors like malnutrition, if she is having any substance abuse. So all these have to be looked for during antenatal period. Correction of anemia, prompt detection and institution of therapy to avoid complication. Then treatment. At home treated as in placenta previa and shifted immediately to well-equipped hospital. At hospital, assessment of the case, emergency measures are management options, definitive, management of complication and expectant management. Management of abruption. Let us begin with the history taking. The presenting symptoms is vaginal bleeding, present in 70 to 80% of the patient. Ask for the nature of bleeding, whether it is dark colored or fresh colored, it is non-clotting and the amount of bleeding. Then second is abdominal pain, probably indicates extravasation of the blood in the myometrium, and in severe case, pain is sharp, severe and sudden in onset. Next is examination, general physical examination. Patient is usually conscious. The pulse is tachycardia, thready pulse, which is a sign of shock. Blood pressure is low. Again, there is a sign of severe shock. And high BP may be present in preeclampsia. So one may get confused whether there is sign of shock or patient is hypertensive. Look for the pulse. Look for the extremities. Cold, clammy extremities as again a sign of shock, and external sign of trauma. Sometimes patient comes with a history of fall or a road traffic accident, and she has, or a home family violence, and she has been beaten by somebody. Then there is possibility of bleeding, internal bleeding, that is, which is abruptio placentae. Uterine contractions are present usually in 50% of the patient, usually very frequent, may be hypertonous, may be difficult to distinguish between abdominal pain. Inquiry about nature of pain, whether constant or intermittent. It helps in differentiating between the two. Then fetal movements are present or absent. Look for the risk factors. History of high blood pressure records during antenatal period, pedal edema, headache, blurring of vision, epigastric pain, history of trauma or roadside traffic accident or history of some home violence, history of smoking or cocaine use, history of abruption in the previous pregnancy, and history of thromboembolism in the patient. On examination, note the increased size of the fundal height. As you remember that in the concealed variety, the fundal height is more than the period of gestation because of the collection of the intrauterine blood clots. Then increased abdominal circumference, uterus is tender, woody hard feel of the uterus in severe cases, difficulty in palpating the fetal parts, and there is no feeling of uterine contractions, absence of fetal heart on auscultation. Local examination. On per speculum examination, blood clots are seen in vagina, cervix may be dilated as 50% of patients are in labor. Then on per vaginal examination, always remember, regard all cases of abruptio placentae, APH, that is antepartum hemorrhage, as placenta previa unless proved otherwise. Never do a per vaginal examination until placenta previa has been ruled out by ultrasonography. When indicated, amniotomy shows blood-stained liquor is seen. So always when a patient comes with the suspected antepartum hemorrhage, there can be a possibility of placenta previa or abruptio placentae. Always before doing a per vaginal examination, advise or get a sonography done to localize the placental position. If it is placenta previa, then if you do a PV examination, patient will have a torrential bleeding and she may go into sudden shock. So always remember to not do per vaginal examination directly before the ultrasonography and localizing the placental location. Baseline investigations are required like blood group and RH typing, complete blood counts with platelets, liver function test, kidney function test, bleeding time, clotting time, and urine analysis for the urine protein and ultrasonography. Other investigations are specific workup for the gestational hypertension. If the patient is hypertensive, then look for HELP syndrome and hemolysis, platelets, liver function tests, fundus, then screen for thrombophilias. If coagulopathy is suspected, get the PT, PTT and INR. Fibrinogen less than 150 milligrams per deciliter suggest coagulopathy. Get the fibrin degradation products done and D-dimer test. The diagnosis of DIC is done when fibrinogen level is normal between 150 to 600 milligram per deciliter. If it increases, then PT, that is prothrombin time, is between 11 to 16 seconds. If it increases more than this, if PTT is 22 to 37 seconds, which increases, platelet counts usually is above 1 lakh. If it is less than 1 lakhs, D-dimer less than 0.5 milligrams per liter. If it increases, that indicates DIC. FDPs less than 10 micrograms per deciliter. If it increases, again indicates DIC. Increase in thrombomodulin. Include thrombomodulin plus USG. Findings suggest as double marker test which detects the abruptio placentae. Role of sonography in diagnosis of abruptio placentae. Remember, regard all cases of antepartum hemorrhage as placenta previa unless proved otherwise. The ultrasonographic studies is done to rule out placenta previa as the cause of antepartum hemorrhage. Placenta abruptio is a clinical diagnosis. Do not delay definitive management for ultrasound confirmation of abruptio. Ultrasound itself is not very useful in the diagnosis of abruptio as placenta and acute hemorrhage appears similar on the sonography. Finding suggestive of placental abruptio is sonolucent area between the placenta and the uterus, rounding of the placental edges, and placenta appears thick. In this ultrasonographic picture, you can see that this hypoechoic area is seen, which is the blood collection behind the placenta, and this is the fetal sac. So this is how the hypoechoic area it appears on the sonography. As I have told previously also, ultrasonographic main role is to rule out placenta previa but not the diagnostic in abruptio placentae. Early hemorrhage is hyperechoic or isoechoic. Negative findings do not exclude the placenta abruptio. Here in this sonographic picture, you can see that there is an organized blood collection which is hyperechoic in appearance. So this is again another feature of the ultrasonic presentation of the abruptio placentae. Now let us see the factors guiding the management of abruptio placentae. Number one is the severity of abruptio. Second is the maternal and the fetal conditions. Third is gestational age. And fourth is the associated complication. Management, immediate intervention is call for help. Intranasal oxygen as patient may be in shock. Keep patient warm. Obtain immediate intravenous access. Two large pole intravenous cap, that is 16-18 gauze, have to be inserted Send blood for investigations and cross-matching simultaneously. Arrange 2 units of blood and blood components. Adequate amount of blood components have to be arranged. Immediate intervention is initiate blood fluid resuscitation, give Rinker lactate till the blood is available. Another choice is normal saline. Call for immediate obstetric and neonatal support. Packed red blood cell transfusion is needed, so ask for it. Fresh frozen plasma transfusion is needed and platelet transfusion is needed. Another thing required can be recombinant factor 8 and ROGAM if the mother is Rh negative. Close monitoring is required. Blood pressure and pulse have to be monitored half-hourly. Monitor intake and output. Keep urine output over 30 cc per hour. Monitor hemoglobin and hematocrit platelet counts. Keep hemoglobin level about 10 grams per deciliter or hematocrit target is above 30%. Monitor the coagulation studies, fetal heart activities and is to be on the continuous monitoring. Now let us see the management, severity of the abruptio, condition of the mother and the fetus and the gestational age. These 3 factors determine the management, whether immediate or expected management is required. In the immediate management where the mother is hemodynamically unstable, severe abruption is there, patient has developed complications like DIC, renal failure, fetus is death or there is fetal distress and the fetal gestation is more than 37 weeks. So in these category, immediate delivery is required. If the fetus is dead, then vaginal delivery can be tried by induction and ARM, and oxytocin augmentation and vaginal delivery can be attempted. Whereas if the fetus is live and there is normal fetal heart rate or there is abnormal fetal heart rate. If the fetal heart rate is normal, then expectant delivery can be done by vaginal route. But if there is fetal heart rate is abnormal, then the uterus is tense and tender, indicating abruptio of higher grade, then cesarean section is required. Then in the expectant management, where all these factors of severity are absent and there is mild abruptio, that is grade 0 if you remember, and the gestation age is less than 37 weeks, mother is hemodynamically stable, there is no evidence of fetal distress, then give corticosteroids, betamethasone for lung maturity if it is the fetus gestational age is less than 34 weeks, close fetal and maternal monitoring, ultrasonographic monitoring if initial small retroplacental clots are seen, and termination of the pregnancy is done after 37 weeks or fetal maternal condition deteriorates anytime. So this is in short about the management. Lastly, we'll talk about the treatment of DIC, restore and maintain the circulating blood volume. There is no role of heparin and antifibrinolytic drugs. The newer treatment is human recombinant factor 7A, which complexes with tissue factor and activates factor 9 and factor 10, which then synthesizes thrombin. So given in a bolus injection of 60 to 100 micrograms. With this, I thank you all for listening to this lecture. I hope it was beneficial to you all. Lastly, this quote, the lovely thing to learn from water is to adjust yourself in every situation, in any shape, but most importantly, find your own way to flow. Thank you all.